Good morning, everybody. Thank you for joining us today. We have a special pleasure of having Nick Lewis from, who's an ENT surgeon, rhinologist from United Kingdom. He works in Barts Health System. He's going to give us a lecture today on Epistaxis. And we're all going to have a great opportunity to learn something new if we don't already know it. So, Nick, please, the platform is yours, and again,
right, thank you.
Time.
Thank you, Richard, and thanks very much for asking me to speak. And I'm Nick Eynon-Lewis. I'm an ENT surgeon from London, as Richard said. And I'm based at St Bartholomew's Hospital, which is a very old hospital, founded in 1123, and the Royal London Hospital, which is a relatively new hospital, which was opened around 9 years ago. And it's a big hospital with the best part of 1,000 beds. And we had 450 COVID patients admitted in the recent second peak. Right, and so I'm going to talk about epistaxis today, and the brief is really to talk about the practical management of epistaxis. But I'm sure we'll have a chance to touch on some of the recent advances and controversies. And I know that the attendees have various levels of experience and training, so I'll try to cater for that, and I'll be very happy to answer questions at the end of the webinar. So epistaxis is a common emergency. In fact, it's the most common emergency in the UK. And the management does vary quite a bit between different institutions and countries. And it will certainly depend on the expertise and resources that are available at the time. Direct therapy, which refers to identifying the vessel and essentially cauterizing it, is the most effective way of treating it. But often you can't do that. We'll talk about all the various options that are available. There's generally there's a bimodal distribution of the incidence between children between 2 to 10 and adults over 45. Although in the UK, most of the admissions are in elderly patients, and the median age in a recent study was around 70. So you can really divide it into the acute management, which is normally in the emergency department, and management of recurrent episodes, which is very often in the clinic. So we know that the nose has very good blood supply because it has to warm and humidify air, and we breathe over 10,000 litres of air a day, and so it has a very rich supply. The mucosa on the septum is firmly held down to the bone and underlying cartilage, and is therefore rather vulnerable to trauma. And in terms of the classification can be quite useful because it will determine your management. There's no universal classification, but certainly a useful way of doing it is to identify primary cases where there's no associated pathology, and secondary cases, and then of course anterior and posterior bleeds. And anterior bleeds are more common. Fortunately, they're much more easy to manage, and we'll talk about those in some detail. You can also divide it into acute and recurrent. So in terms of the blood supply, the two most important arteries are the sphenopalatine artery, which is a branch of the external carotid, and the anterior ethmoidal, which is a branch of the internal carotid. In terms of the sphenopalatine, it's one of the 6 terminal branches of the internal maxillary artery, which is given off in the pterygopalatine foramen, and it enters into the nasal cavity through the sphenopalatine foramen, and very often it will branch before it enters into the nose. And we'll talk about the anatomy in more detail when I talk about ligation of the sphenopalatine artery. But it basically gives off posterior septal branches and posterior lateral branches. which may be given off before it actually enters the nasal cavity. The ethmoidal arteries, the anterior ethmoidal is more important. It's the larger of the two. And in a minority of cases, the posterior ethmoidal is actually absent. But it has an interesting course. It's a branch of the ophthalmic artery, which is a branch of the internal carotid. And the artery goes through the anterior ethmoidal foramen and lands in the anterior ethmoid. The position of the artery there does vary, and it may be as low as 5 millimeters below the skull base in a bony mesentery. And not infrequently that is dehiscent, probably up to maybe 40% of cases. So it gives branches to the surrounding sinuses, and then it goes up into the anterior cranial fossa and gives meningeal branches and forms a nasal branch, which goes back through the cribriform plate into the nasal cavity. And that then divides into septal branches and lateral branches, one of which actually supplies the skin and goes through the junction of the cartilage and bone at the upper third of the nose. Quick word about Kieselbach's plexus, which is really an area at the anterior septum, which takes supply from the ethmoidal vessels sphenopalatine, greater palatine, and superior labial. And it's an area that's very often involved in epistaxis, particularly in the younger patients. There's some evidence that vessels in this area have a relatively low, smooth muscle content, and they struggle to vasoconstrict. And I'll talk a bit more about the management of these cases shortly. So the initial management, so when we're talking about epistaxis, it really does vary between, drop of blood on the tissue through to life-threatening severe epistaxis. And so if, depending on the severity, in severe cases, obviously you're going to be thinking about resuscitation. And you may, if it's really pouring, you may need to even book a theatre and put a pack in the nose and take it from there. But in the vast majority of cases, they are relatively stable by the time you get to the patient. In the severe epistaxis, you may need to take the history while you're doing the examination. So in terms of the history, I've put down, the first point I've put down is to reassure the patient, because it's very important to remember that for the patient, this can be a very anxious time. And we all know that a small amount of blood can look like a sort of horror show. So the patient's invariably anxious, especially in times of COVID when they're often on their own. And of course, this puts the blood pressure up, and we'll talk about that. Initially, you really want to find out what side the bleeding is coming from, because very often it's coming from both sides, and the patient will say it's bleeding from both sides. So you really need to ask which side it started from, and then document that in the notes. Because if you do have to take the patient to theatre, and especially if you're tying off or ligating a sphenopalatine artery foramen, sphenopalatine artery, for instance, you really want to know the side. Check for a history of trauma. They may have a history of trauma, 3 or 4 days before, and they've been having brisk episodes of bleeding. And, if that is the case, you really want to think about an ethmoid fracture, and you need a CT, and you need to keep them in. Obviously, some of these patients will have a history of surgery. And if that is the case, I certainly recommend contacting the surgeon and talking to the surgeon about what's going on. And very often they'll want to be involved as it's their patient, and they may give you quite useful information about what went on in the procedure. In terms of blood pressure, the studies have tried to sort of untangle this really, because a lot of patients who present to the A&E will have raised blood pressure, but trying to work out whether this is actually a cause of the epistaxis is quite difficult. But certainly if it is very high and it's persistently high, you may need to give them something to bring it down. And you need to keep an eye on that closely. Very important to ask about whether the patient's taking anticoagulants. It's very common in the elderly population in the UK. And if they are taking an anticoagulant or an antiplatelet medication, you really need to know why they're taking it, because there's a huge difference between the patient that's had stable AF for the last 20 years or the patient that had cardiac stents put in a couple of weeks before. And some patients may have a metallic heart valve, for example, and they're running their INR at 3.5, and you need to know about that. And you also want to ask them when they last took their last dose. In terms of examination, of course, in the times of COVID, you need to have proper PPE. But even before COVID, you need to have proper protection. And not infrequently, some of the elderly patients may have a degree of COPD and they're sort of spraying out the blood all over the place. And you really need to, I would advise having a visor. You really want to have an assistant, so a nurse if possible, or someone else. And you need to get the patient in the right position. So you want to sit them up a little bit, or get them sitting in a chair, and give them a vomit bag or a kidney dish and something to spit the blood out into. You want to put the couch up to the right height. So these things do make a difference. So you want to really get in a nice position to be able to examine the patient. A good headlight is absolutely crucial. And even if you don't have a proper headlight, a head torch will be really helpful, because then you have two hands free to examine the patient. And the initial examination is really looking into the nose, which we call anterior rhinoscopy. And it's really a scouting view. So you're really looking to see how the land lies. You may see an anterior bleed, or you may not. You may see a nose that's full of clot or bleeding actively. And then it's a process of applying local anaesthetic and vasoconstrictor and gently suctioning the nose. And some patients some clinicians ask the patient to gently blow their nose, but I would advise just gentle suction. And you may suction the patient, apply vasoconstrictor and local anaesthetic. In the UK, we tend to use something called cophenolcaine, which comes as a spray. But we also sometimes apply, lignocaine or adrenaline on a cotton wool pledget or a pate. And you're really trying to get things under control so that you can then examine the patient with an endoscope. So if it's not an anterior bleed, it's terribly important to be able to examine the patient with an endoscope and look for the bleeding point. And it's not just a question of putting the endoscope in and, seeing if it's coming from the front or the back. It's a question of systematically looking around the nose. So you want to look at the lateral part of the posterior nasal cavity where there's a venous plexus, look around the area of the spina palatine, the middle turbinate, and look around the area of the anterior ethmoid. And, certainly the studies show that if you look really carefully, take your time in your patient, very often you can find the bleeding point. If you can find the bleeding point, you've got a decent chance of being able to coagulate it and avoid packing and avoid a hospital stay. And there's one or two pictures. So you can, a rigid scope is really useful because you've got the other hand free for suction. But also a flexible scope can be really useful for looking around in the nasal cavity. And head mirror or a head torch is vital. So just turning to etiological factors. So trauma to the nasal mucosa can be relevant, and especially in children. They have a great tendency to pick their noses, as we all know. I saw it written down as, it was called Epistaxis digitorum, which I thought was a rather nice way of putting it. But in adults, very often these patients can have a tendency to to develop crusting and scabbing sometimes in the nose, and then they blow the nose and they obtain improved nasal airway for a while, and then the crusting and scabbing comes back, and they get into this cycle that can sometimes go on for years. And underlying that crusting and scabbing is very often a degree of inflammation of the nasal mucosa. And I'll talk about anterior bleeds in adults shortly. Very often, well, sometimes patients will have septal perforation, and of course you will want to be thinking about the cause of the perforation, investigating that further as required. You can have drying of the mucosa of the nasal lining. Sometimes patients have had oxygen therapy. And of course, always remember that they may have a neoplasm or a vascular malformation. Some neoplasms of the nasal cavity, when you look at them, they will bleed. And if you just go in there with a sucker, you can suddenly find you've got absolutely horrendous bleeding on your hands. So just be careful. In terms of systemic factors, we touched on hypertension. Atherosclerosis is a factor in the elderly population, and they may well have be on anticoagulants, or obviously you're going to check for clotting disorders. Always think about hereditary hemorrhagic telangiectasia, and they may have some other pathology of the nose, and in countries other than the UK, they may have other pathology that's more important. I saw a paper from the DRC talking about sickle cell anemia causing bleeding in children. And I saw a paper from Mali, from Bamako, where atrophic rhinitis was an important cause of epistaxis. And of course, conditions such as typhoid and dengue fever can also be associated with epistaxis. Okay, quick revision of warfarin, which is most commonly used anticoagulant. And going back to medical school, I'm sure you can remember that it impairs the synthesis of the vitamin K dependent clotting factors 2, 7, 9, and 10. It's important to realize if you stop warfarin, it does take around 5 days until normal hemostasis is resumed. And it also takes 2 or 3 days to work when you start it. I put this in about liaising with the hematologist or cardiologist. This is terribly important because the medicine involving clotting disorders and anticoagulants is quite a complex area of medicine. And I think it's much better if you're, even thinking about stopping the medication or some other therapy, just to talk to the on-call hematologist and document that in the notes. I strongly recommend that. Review in 2016 in rhinology gave some advice, which I think is quite sensible, and that's that the default mode is continue the anticoagulant. But if the INR is over 6, then you consider vitamin K. If the INR is high but less than 6, then you'll start withholding the drug. But if you do have life-threatening bleeding, then you need to give clotting factors in the form of prothrombin complex, or if that's not available, FFP. Now there's the new or novel or direct oral anticoagulants are becoming more and more common in the UK, and there's a range of these drugs that work in different ways. But the difference is that they tend to have a short half-life, and so withholding the drug can be really quite effective. They do have, some of them have reversing agents, and you'll obviously need to discuss that with hematology as required. Paper in Laryngoscope this year found that rivaroxaban and apixaban were actually not associated with an increased risk of severe epistaxis and hospital admission, which is quite interesting. Antiplatelet drugs, of course, aspirin and clopidogrel are the ones that we tend to see in the UK. And they inhibit platelet aggregation. But again, importantly, withdrawal of the antiplatelet agent will take several days to take effect. And so that's obviously very relevant. You may need to consider platelet transfusion. So you can divide epistaxis into anterior and posterior. The anterior ones, as I say, are in the younger patient, less severe. usually on the nasal septum, much more manageable. The posterior ones are in the more elderly patient. The really difficult ones are the posterior ones in elderly patients with comorbidities, and very often they're on anticoagulants as well. Right, so we'll turn to the treatment options. We already mentioned some of the medical options that we have. In terms of intervention, we'll talk about packing and local hemostatic agents. And then I put cautery down under the surgery section. But then there's also septoplasty and arterial ligation, and there is a place for embolization in some centres. Bleeding from the anterior septum, the Hippocratic method, where you basically just pinch the soft tissues of the nose, can be really quite effective. And it's amazing how many patients and sometimes medical staff are pinching in the wrong place. But that can certainly be effective if you have an anterior bleed. And then we're looking at cautery. Silver nitrate can be very good in the clinic. It can be quite difficult if you've got an active bleed going on in the emergency department, where electrocautery can be more effective. And in terms of using silver nitrate in the clinic, you want to apply vasoconstrictor and local anaesthetic to the Little's area. And then you look for the vessels. And in this particular patient, I'm not sure, can you see my arrow, Richard? Yeah. So in this patient, there's 3 prominent vessels. Very often there's just one prominent vessel that lends itself to cautery. If you see this kind of appearance, then you're going to be suspecting hemorrhagic telangiectasia, and they need to be referred, and they need to be screened for AV malformations in the lung and the brain. The idea about the cautery is that it's not really demonstrated that well on these slides, but you cauterize around the vessel, and then you cauterize the middle. And not infrequently, you have some silver nitrate that can kind of go down onto the upper lip and cause a stain. And it's a good idea to put some cotton wool there just to soak up the kind of mucus stained with silver nitrate. Then I normally give the patient Naseptin for 10 days or so, which is a combination of chlorhexidine and neomycin. So recurrent minor bleeds, we've touched on this really. You may find using a nasal douche helpful, as well as avoiding local trauma in the case of nose picking in children or forcibly blowing the nose in adults. So in terms of packs, you can divide them into non-absorbable and absorbable. Non-absorbable packs that we use in the UK tend to be Mericel or Rapid Rhino. I'll talk about those in a second. And historically, we've used gauze impregnated with BIP for many years, but this tends to have gone out of fashion really with some of these other packs. But we will mention that. Absorbable nasal packs can be really excellent. And there's certainly a place for those. And in some countries, Surgistal and Spongistan are quite used, frequently used. Mericel pack, which is our sort of basic go-to pack, and a note for the more junior clinicians that when you insert the pack, you insert it along the floor of the nose. Sometimes you see the pack that's sort of inserted along the dorsum and they're kind of hanging out here, but you really want to, the pack goes right back. And then you put water on it and it will expand. And the idea is that it causes a gentle tamponade. But it's a non-absorbable pack, so you will need to remove it. And in the past, we used to put these packs in quite frequently. Say 20 years ago, we used to put them in quite frequently after nasal surgery. But patients really don't like having them removed. So we very rarely use them routinely now. It's just really for epistaxis. A pack that is used quite widely in the UK is Nasapor, which is a fragmentable dressing. It's probably not quite so hemostatic as Mericel, and there's studies that have looked at this, and there's a discussion to be had about that. But it does have certainly has the advantage of being fragmentable, and so it's widely used after routine nasal surgery. The Rapid Rhino is something that's used in the hospital that I work in, and it's really a quite many ways, it's an impressive invention, because it's a balloon that's surrounded by this sort of fiber that's impregnated with carboxymethyl cellulose, which is a platelet aggregator. And you put the pack in some water and it kind of self-lubricates itself. And there's a diagram, and it tends to go in it's very easy pack to use. You put it in the nose and just blow it up. Of course, epistat balloons and Foley catheters have been used for many years, and they can be highly effective. And you can see that these devices are full of water, which is probably the preferable to air. But the general message is that balloons really can be quite uncomfortable. They have fairly significant complications, and you know, on the whole, we're trying to move away from balloons. There are instances where you will have to just put a balloon in when it's pouring, but as a general rule, I would advise against using balloons. And they tend to traumatize the nasal mucosa quite a bit, and very often they might not actually be causing tamponade on the area that's bleeding. And in this slide, you can see there's a Foley catheter in. And the way to do it is to, you put it through the nose, you look through the mouth, you see the tip of it, put 10 mils of water, and then just pull it backwards until it's kind of fits, and it's reasonably comfortable for the patient. You then put an umbilical catheter or some kind of clip on it to stop it from going backwards. You can then pack onto it with BIP, or you can put another balloon in the front, or you can put a pack in, or you can put a pack in the front. And there's BIP, which I'm sure in many countries is still used widely. I worked with a doctor from India once who said that he treated every epistaxis with BIP packing, and it'd always been successful, and I absolutely believe him. The trouble with packing a nose with rib and gauze is it can be pretty uncomfortable for the patient, and it is a skill that you have to learn. And the key is that you put the BIP in along the floor of the nose, and then while you take your Tilly's forceps or nasal dressing forceps out, you'd have to avoid pulling out that piece of the pack. And it never looks like this, but it's a very good skill to have, and it's certainly effective. As I say, packing the nose, whether it's balloons or nasal packs, they do have complications. Of course, they can be displaced. A word about packing the nose: you really want to pack one side if you can, because if you pack both sides, the patient then has that complete nasal obstruction, which can lead to apnea, and can be a real problem. If you can get away with one side, it's much better to do that, and you can put some decongestant in the other side and give them an airway. Of course, toxic shock syndrome is a very rare complication of packing, but it's something just to be aware of if the patient does suddenly becomes unwell. And it's usually due to toxins from a staph or a strep. The other complication, certainly of a Foley catheter, is alar necrosis. And you have to be very careful of that, because everybody's thinking about the nosebleed and nobody's really thinking about the alar margin. And this is, I wouldn't say a common complication, but I've certainly seen it on more than a couple of occasions. We then turn to local hemostatic agents, which are in many ways, some people would say, the future. And there's a whole host of these agents, and of course their availability is really variable, and their cost is really variable as well. But they either stimulate or augment the endogenous clotting cascade, or there's a number of substances that can be, some of them are inorganic based hemostats, and I'll talk about those. There's just a list of them, and those are just some of them. In the hospital I work, we use Flow Seal, which is a gelatin thrombin matrix, Many hospitals will use Surgistal, and you can use it in different ways. Some people have even sutured it to the septum. And there's a number of tranexamic acid is something that's quite widely available, and I'm going to talk about that a little bit in a minute as well. This is a diagram showing the use of flow seal, which is really adding thrombin to an actively bleeding wound, and that actually works really well. It's been used in cardiac surgery quite a bit. And some patients that we don't want to admit, we can actually insert this into the nose in the emergency department, and they may be able to go home. But conversely, if you have a bleed that you just can't control, or post-operatively you're just struggling a bit, flow seal can sometimes come to your rescue. This is a product I used a couple of weeks ago. It's a very simple thing. It's synthetic peptide, which it really just forms a coating over the area that's bleeding, and is relatively non-toxic. Tranexamic acid, again, reasonably widely available. It's a systemic inhibitor of fibrinolysis. It's contraindicated if there's a history of thrombosis, but it can be used orally, IV, or topically. And the studies have looked at this quite a bit, and there's certainly some decent evidence that it's helpful in oral or IV forms, and there's some evidence that it's helpful topically as well. It has relatively few side effects. And there's a recent paper looking at the dissolvable intranasal hemostatic agents and really sort of comparing them to nasal packing. And they found that in the meta-analysis that really potentially the hemostatic agents could be as good as packing. But they excluded patients with anticoagulants, and certainly there's more work needs to be done. But in many ways, as time goes on, the cost of these local hemostatic agents will come down, and they'll be more widely used, I feel. This is a bit sort of busy slide, but I just refer you to this. It's the ENT UK guidelines, and it's out there on the ENT UK website. And it really just shows that anterior bleeding you should be able to control. But if it's posterior bleeding, they've divided it into low volume or profuse. And it's a bit UK centric. They're talking about rapid rhino and Mericel and so on. But basically, you need to try and find the bleeding point. Now, if you cannot find the bleeding point, then you're going to pack the nose with something. And that will very much depend on your hospital and what's available. You then admit the patients. We generally in the UK, we don't send patients home with packs that are non-absorbable, although in some countries they're comfortable to do that. So you've admitted the patient, and generally speaking, we're going to leave the packs in for 24, 48 hours, although of course it may vary. I mean, you may have significant bleeding after 12 hours and you need to take the pack out and have a look and decide what you're going to do. But generally after 48 hours, a decision will be made. You'll take the packs out, usually, and you'll decide you're going to have a look and whether you're going to take the patient to theatre or whether you're going to repack the patient. And it will depend to some extent on the amount of bleeding, and it will also depend on the patient and comorbidities and so on. What tends to happen in many units is that the patient sort of languishes on the ward a little bit, and you can find this if there's sort of handover. It's a different doctor every day that's doing the ward round, so you've got to keep a close eye on these patients. And what we're certainly advocating is to take the patients to theatre early rather than keep repacking. Every time you repack, the nasal lining tends to get more traumatized, and you can end up with a really friable nasal lining. So the indications for surgery is really persistent bleeding as much as anything. Occasionally there'll be a patient that's intolerant or refuses packing. And the other indication is recurrent epistaxis requiring packing or admissions. And what are the options? So the most simple option is to have a really good look in the nose under anaesthetic. So you're going to wash out the nose really well under anaesthetic. And if you can see an obvious bleeding point, then you can cauterize it. And then you have a choice of whether you're going to do a sphenopalatine artery ligation or not. I think if it's an obvious vessel and you're happy you've cauterized it, then I would then send the patient back to the ward. If you're not quite happy, then I'd do a sphenopalatine artery ligation. There is a place for septoplasty. Sometimes the bleeding is from the septum. It might be from the posterior septum, and there's a place for septoplasty, or there's a spur. And then, of course, post-operative patients, you really want to know what's been going on in the surgery. And that's best done, if possible, by the surgeon that did the initial procedure. We're going to talk about sphenopalatine artery ligation and anterior ethmoidal ligation. Last resort is really external carotid ligation. And I think these days, certainly in the unit that I work in, there's no real place for internal maxillary artery ligation. I have seen it done, but we've stopped doing it, to be honest. So you need bipolar forceps of some description, or monopolar. This is a monopolar suction cautery by Valley Lab, and this is an absolutely brilliant product. You can bend it and you can suction and cauterize at the same time. In terms of sphenopalatine artery ligation, we mentioned the anatomy and the fact that when the sphenopalatine artery enters the nose, it's sometimes divided before the foramen. And there are some important relations, but the most important relation is the crista ethmoidalis. The crista ethmoidalis is a little ridge that's sitting in front medial to the sphenopalatine foramen. So the basic technique, we'd normally do it without doing an antrostomy. This is a cadaveric picture, but you make a little flap around 7 to 8 millimeters in front of the back of the middle turbinate. And I'd advise injecting this if you have a dental needle first, and then you may need a pledget with some adrenaline on it, or a neuropate, just to help you with the dissection, as it will bleed a little bit. You go down to bone, you just lift the flap, and when you get to the sphenopalatine foramen, you're either going to ligate it or you're going to clip it. I'll just talk a little bit more about that in a minute. So there's a sphenopalatine artery with a crista ethmoidalis in front of it. You can remove the crista ethmoidalis. And I think there's some surgeons that would kind of explore this area and sort of dissect into the sphenopalatine area looking for branches. Some surgeons would divide the artery and then go looking for the posterior branches. Other surgeons would more or less just bipolar the main branches that they can see and call it a day. So it does vary to some extent on the anatomy that you encounter and also your experience. There are liga clips, of course, but they're not always easy to put on and they can fall off. So I think definitely bipolar is a good idea. And when you're lifting the flap and you're coming up to the sphenopalatine artery, you just need to be really careful because it is a fragile area. As you come up to it, just gently dissect around it. The last thing you want to do is injure the sphenopalatine artery, because then you can have some significant bleeding. This is a picture, you've got some clips on there and it's kind of been fried as well. And there's the clip applicator. The studies show that the procedure works pretty well. You can get some dryness, and there are sometimes reports of numbness in the palate. And I think certainly if you use the monopolar, there is an increased risk of numbness in the palate because of the nasopalatine nerve. But you may not have bipolar forceps that you can reach this area. So in that instance, using a monopolar may be reasonable. Epistaxis with trauma. So if you're suspecting an orbitoethmoidal fracture, or if it looks like the bleeding is from high up in the nose and coming from a branch of the anterior ethmoidal, then you're going to consider ligation of the anterior ethmoidal artery. And so we'll talk about that. You make a Lynch incision, dissect down to the angular vessels and cauterize them. and then you're lifting a flap back to the anterior ethmoid, which is 24 millimeters behind the anterior lacrimal crest. And I'll just show you the anatomy. So this shows it really well. That's the anterior crest, and that's the frontoethmoidal suture. And you can see it just above it there is the anterior ethmoidal foramen. Posterior foramens around 1 centimeter behind that. And then you're coming to the optic nerve. So again, you really have to be careful. I think the anterior vessel is almost always the most important. And bipolaring or clipping the anterior vessel is probably prudent. And in most cases, I wouldn't really go on and start doing ligation of the posterior ethmoidal. You also want to be a bit careful with your flap and retracting your flap. You want to retract that very gently. The thought is not to divide the artery because it can then retract. So I'd just bipolar it personally. And there you can see the Lynch incision, and just gently lift up your flap. And it's relative, I mean, nothing straightforward, but it's a relatively straightforward procedure. You come to the artery and then you can either ligate it or bipolar it. To more recent advances, if you like, some people would do it endoscopically. You identify the ethmoid artery, go through the lamina papyracea, go into the orbit, and then ligate the vessel. But that really relates to bleeding after sinus surgery. And there's a precuruncular approach, which is a very elegant approach to the medial orbital wall, where there's no incision. You just go underneath, just medial to the caruncle. And there's a nice paper from Cape Town describing the studies on that. External carotid is last resort. It doesn't tend to work terribly well because of the supply from the other side. But of course, just remember, if you are going to tie off the external carotid, make sure that you can see 2 branches, because the first branch can sometimes come from the internal carotid. So that's just a practical thing to remember. Embolization, just sort of finishing really. Embolization is, we have a unit in the hospital where I work where they have a long history of embolizing. You certainly need an experienced neuroradiologist to consider this. And the worry is always that there is a small incidence of very significant complications, such as blindness and stroke, and you can't do it to the ethmoid vessels because they're branches of the internal carotid. But there is a place for it. If you do have it available, we sometimes use that facility, but I suspect that there won't be so many units that have that experience. So just to finish on really some tips from my perspective in terms of the assessment: establish the side of the bleeding and document that in the notes. Don't forget about naso-orbital ethmoidal fractures. If there's a history of trauma, be very patient with your endoscopic examination. You may need to do an examination, come out, try and get the nose drier, get rid of some clot gently. Some countries actually wash out the nose. One of my colleagues from Romania, they use hydrogen peroxide, which sounds like a really nice way of doing it, or you can do a very gentle nasal douche. But try and get the nose so it's clearer and go back and have another look. And that time is really well spent at the beginning because you may avoid pact. Good communication with the physicians is essential as required. And generally speaking, I'd say try and avoid balloons if possible. And I think the place for local hemostatic agents will increase. And I think in some ways this may be the future of, to some extent, the future of management of epistaxis. And the general rule these days is early rather than late intervention if you have the facilities to do sphenopalatine artery ligation. Right, and that's the end of the talk, and I'm very happy to answer any questions.
Nick, thank you for the comprehensive approach to epistaxis. And it's been many years because I don't do rhinology anymore. I only do otology.
Yeah.
But we used to do a lot of IMAs. Okay.
Really?
Ligations. Yeah. You mentioned that you don't do them. Okay. So tell me why.
I think the reason is because sphenopalatine artery ligation is kind of taken over. And it's an easier operation to do, and it kind of makes more sense because it's nearer to the nose. And the time when I last saw internal maxillary artery ligation, sphenopalatine artery ligation wasn't invented, or it was. People were doing it, and this is over 20 years ago. But I think it's just taken over, and I think, of course, you've got to do the approach, through the maxillary sinus. It's, I mean, I'm sure if you've done a few, it's not a big deal. But I think, possibly if you haven't done a few, it's not necessarily such an easy operation. I think sphenopalatine artery ligation is easier. But I guess, I'm sort of very interested to know what they're doing in other countries. And I suspect that procedure is certainly, it's still being used relatively commonly in some countries, perhaps.
We have a question here, Nick. Hold on. From great presentation. Okay, thank you for your comment. Let's see here. Okay. Oscar, you have a question? I thought you had your hand raised there, Oscar. Just a second here. Oscar. Oscar.
Yes. Yes, I have one question. So the first question is, how often in your hospital you perform this sphenopalatine ligation? And I never done it on the real patient, but on the cadaver dissection, they taught how to perform this surgery, and they also they always warn not to actually damage the sphenopalatine artery. I can just imagine what is the next step if you actually damage the sphenopalatine artery and it's actually at the level of the foramen. So you don't have an option to put the clip. So what's the next step?
I think that's a very good question. So then, as ever, to some extent, it depends on what you have available. So I think the first thing to do would be to try and cauterize that area. So you could use, monopolar in that circumstance if you have monopolar, and you may have to, if you can't use a bipolar and you can't get a clip on it, and it's kind of pouring, that's one option. I mean, for us also, flow seal, is a really good option in that sort of circumstance. And in some places they may or may not have flow seal and may not have any other facilities. So we kind of, I don't know if do you use, which country are you working in?
I'm from Ukraine.
Okay. And do you use local hemostatic agents much?
Yeah, it's common. You usually use on the platelets like lidocaine, 10%, and with epinephrine.
Yeah, but the flow seal is a specific agent that's basically applying thrombin to the area. And when it first came out, they have pretty impressive demonstrations where somebody's made an incision into a pig heart, I think it is, and they hold the flow seal over and it stops the bleeding, sort of major bleeding. And if you don't, but if you can't control it, I mean, so I think firstly, I can't recall a situation where that's happened. I mean, I'm being a bit conservative, telling you to be very careful, but you need to be very careful. But I can't recall a situation where that's happened, as long as you're just careful lifting that last piece of the flap. And if it does happen, I think you can cauterize the area and put pressure on it. And then you can pack it. you may need to put, but you know, there's lots of things you can try and do. Ultimately, the last thing you can try and do is tie off the carotid. But even then, you know, that's not a great option. I mean, in our unit, we could potentially embolize it. So we might do an emergency embolization if we were in that situation. We've never had to be in that situation. So I think with epistaxis, it's very much a question of working with what you've got. And in some units, and I've had a patient with a severe epistaxis in Malawi, and you know, you have to use what you have. And what they do have there is tranexamic acid, and they have ribbon gauze, and they have cautery. You know, it can be, but I think it's not common. It's not a common complication. I think most people would say, you know, when you do it on a patient, you'll find that you're okay. It's unlikely to be a big problem unless you're very, you know, very forceful with that last piece of the flap. And you're not going to be, because you're going to be aware of it. I think that the complication probably comes when somebody's not aware of that complication and they're just lifting the flap and they don't think that, yeah, maybe there could be a problem. I think in your case, you're going to be fine.
And is it relatively safe to try to cauterize with a suction monopolar device this artery?
Well, it is safe. You do run the risk of having some palatal numbness potentially with the monopolar. But certainly if you were in a situation where you couldn't control the bleeding, I would certainly do that. Okay. And it's highly effective with the monopolar suction. I don't know if you have the Valley Lab monopolar suction cautery, but it's a really fantastic device. And it's very good also for bleeding after an adenoidectomy, for example, where you can cauterize it endoscopically.
Thank you.
Okay, Nick, there's a couple more questions. One was, if a patient has recurrent epistaxis, at what point do you consider doing a suprapalatine artery ligation?
It's phenopalatine, but so I think it's true to say that each patient is different, because as a general principle, if you've had to pack the patient, and you're really talking about posterior bleeds, the sort of general timing is sort of, you know, 48 hours of packing. Now, if at 48 hours, well, they had a brief bleed, you know, and they're fit and healthy, and they're kind of okay, then you might leave the pack in a bit longer, or you might take the pack out, have a look round. You might find in the clinic that there's a bleeding point, or that you can put some other hemostatic agent in, or so on. But if at that point, after 48 hours, the patient's having relatively significant bleeds, and that, you know, it's difficult to put a volume on it, but certainly if they're dropping, some people have said, you know, if you're dropping your hemoglobin, you know, 3 or 4 points. But I think the general message is that we're very happy to take the patient to theatre early rather than late, because one thing that you can do is have a really good look around, and you can wash out the nose properly. So you might take the patient to theatre, you might not do a sphenopalatine artery ligation, but I would have a relatively low index of doing it. Of course, the problem is, to do it, you've got to have a theatre and you've got to have a surgeon. The problem that we normally have a surgeon, and the registrars, I think they're all pretty much comfortable in taking patients to theatre. I mean, I have to be honest, as consultants, we don't actually go in, and we're not called in that often to manage these cases because the registrars are so good. But we do come in sometimes to see them, but you need theatre space. Now, at the moment, with COVID, getting theatre space is a nightmare. So I mean, talking to the juniors as well, the practices have slightly changed during COVID. So we're trying not to admit patients. we're trying to deal with them in the emergency department and see if we can send them home. So we're using more hemostatic agents, non-absorbable packs, trying to cauterize them. And, you know, just getting a patient on an emergency list at the Royal London. And there are hospitals where you have theatre just waiting and you can get the patient there whenever you want, 24/7. But that's not true in the hospital that I work. We don't have that facility because there's so many emergencies. Unless you know, if it was pouring, you could get the patient to theatre. But if it's a bit on and off bleeding and you want to do an SPA ligation, you may not be able to get the patient to theatre. But that's a variable that we can't really control.
Thank you. There's a triple loaded question from Thomas from Lithuania. The first part is that, do you have a centralized treatment center for HHT, Oslo Weber Rundu in United Kingdom?
Well, I think the answer is yes, really. I mean, the National Throat, Nose and Ear Hospital with Gray's Inn Road, which is kind of amalgamated with UCH, has been the national, probably the centre where they've seen more patients than anywhere else. But I'm not 100% sure if that, certainly, I mean, if you're interested in knowing more about that, you can certainly email me and get the email from the NatGeo.
Okay, the other question is, what treatment options do you use for patients with HHT? That's the second part of it.
Yeah, so so I tend to refer them to a colleague. So we do separate it out. I mean, of course, you know, you can cautery, you know, people have been lasering them. You can use bipolar, works perfectly well for these lesions. And then there's a whole number of different sort of medical treatments that people have tried. And then ultimately a Young's procedure where you close the nasal cavity. And you may want to leave a little bit open so that they have some kind of nasal airway. But I think the most important thing is that they are referred to, you know, a clinician that has a multidisciplinary clinic that deals with them. And probably the most important thing is that they're screened for these AV malformations. And you probably need to screen first-degree relatives and so on. And the management of HHT is probably a webinar in itself in a way.
Okay, and then the last part of this question from Thomas from Lithuania is, what is the last resort for patients with HHT, in your opinion?
Well, it's the Young's procedure, really, where you close the nasal cavity. But the trouble with that is that gives them no nasal airway. And there's a big difference between having no nasal airway and having a bit of a nasal airway. So I think the thinking now is to leave a small area of patency. But of course, it is a life-threatening condition. You know, it's difficult to manage, and I think, but it's certainly, I think half the battle is to identify these patients and refer them.
Okay, and then we have another question. I believe this is the last one from Aziz in Swaziland, which is part of Somalia. And he asked a question, is there a role for warm nasal washing of the nasal cavity in bleeding control?
Yeah, so I think that's also a very good question, because washing the nose, some people have you know, washed the nose out hugely with warm water, or even some people do it with cold water. And I think certainly, I think the short answer is yes. I think it's a really good thing to wash out the nose. And I think possibly what we should be doing, although we don't really do it, is use a Neomed nasal douche in certain patients. I mean, some patients you can't do it in the emergency situation, but just a gentle nasal douche, just to start washing the nose, I think is really good. It cleans out the clots and it probably is hemostatic. So some people do that a lot after routine nasal surgery. And I'd certainly wash out the nose routinely after nasal surgery. And I think, you know, I certainly, you know, it works quite well on two levels. Certainly washing out all the clots, but it may also be hemostatic. I haven't looked at the papers on that, I have to be honest, but I know some people are very keen on doing that.
Okay, very good. Any other questions? Looks like we've had the questions for the day. Nick, thank you very much. On behalf of my colleagues across the Atlantic, across the Mediterranean, across the Pyrenees, across the, what else? I'm not sure what the mountain chain there is, but anyway, I want to thank you for your time, your expertise, your sharing of your knowledge with our group of interested physicians. And if anybody has any further questions, put them on the chat for WhatsApp and we'll make sure that we get it to Nick, okay?
Yeah, I mean, if anybody has any queries at all, just get in touch with me via the organization. I'll be very happy to speak to them and email with them.
As a matter of fact, Nick, I'll put your email address on the
yeah, that's fine.
And they can, and anybody who's interested, you can write to you directly. Okay.
Yeah, that's fine.
Okay, Nick. Listen, thank you. I'm looking forward to coming to the museums in London.
Yeah, I'm looking forward to it.
As long as it's not a wax museum, and we'll be we'll look forward to meeting again soon. So thank you very much for your time. Okay.
Okay, you're welcome. Thank you for asking me to speak.
Okay, thanks again.
Take care. All the best, and bye everyone.